Yeah, I am pleased to introduce our first presenter today. I'm Dr. Lindsay Weaver. Dr. Weaver is the Chief Medical Officer for the Indiana Department of Health. She has been working tirelessly this past year on the COVID response, and she is currently leading the vaccination effort. We want to thank her for being here today, and we look forward to your presentation, Dr. Weaver.
Thank you. Thank you for having me. I'm really excited to have this opportunity to speak to all of you. I just want to start off with a thank you. Thank you for everything that you have done this year. But to also let you know that I'm going to come with some asks of you as well through this presentation. So I hope that you find it informative, and I look forward to your questions. Ashley, do you want me or Becky to share my slides? Yes.
Is it working?
It is working. Next slide. Just a reminder to everybody, please sign up for IHONs, even if you are not a clinician. We do find this to be our best way to push out medical information very quickly. For example, last week, was it just last week? That seems like forever ago, but when they came out with the pause for Johnson & Johnson, we immediately, as soon as we got the information that we needed to send out to everybody, we used the IHON in order to send out that information. So we plan to do the same thing as we learn more information, or if anything else comes up the road. So please sign up for these to get the most up-to-date information. We tried not to overuse it. So everything that we send, we do believe is important, and we want clinicians and anybody in the healthcare field to get this information right away. Next slide. So I think it's always important to take some time for a little bit of reflection about, where have we been before you can talk about where we are and where we're going. So it was just a little over a year ago when we had our first case on March 6th, and then had our first death on March 16th. And as you know, those numbers have just risen tremendously over this past year. March 30th was our date for our highest number of hospitalizations across the state, and that was 3,400. So we hope to never see that number again, and that is what our goal is with all of these vaccines. Something little known to people, but for the first about 4 weeks of the COVID-19 response, so back in March, the Department of Health leadership team was actually calling every single individual with their positive case. So we would call the individual that was positive, we would call the provider who did the test so that they could do proper contact tracing, because back then, remember, we weren't doing the full, we weren't masking all the time in the hospitals for that short period of time. And then we would also call the local health officer. So in the beginning, these were 1 o'clock in the morning, 2 o'clock in the morning phone calls. And it was just such a scary time because there was so little that we knew about the disease. So I also have a background in palliative care and having difficult conversations with people. And I'll be honest, I have used those skills more in this last year than I did back when I was a palliative care physician, to just even talk to patients and clinicians and leadership, et cetera, about, what's going on and their fears and their most worries and what they hoped for the future. Next slide. So what we were dealing with then, of course, was, we didn't know how these people would present. We were very unsure about treatment. Testing was so difficult. Remember that back then, right? That people were, big borrowing and stealing to get tested, and we had those certain criteria, and it took several days to get back. PPE was such a difficult thing for us. We didn't know what the risk of were to clinicians and the risk to our families, right? That we knew that we needed to be where we needed to be. So in the hospitals, taking care of patients, but what did that mean for the rest of our lives? So we are in a better place in that we know these things. We know how to protect ourselves. We know how to protect our family. We're better with how we can approach these patients and treat them We can identify someone with COVID the second they walk in the door in the emergency department now. We have abundant testing and are doing much better with our PPE. So there's so many things that really make us in a better spot. But unfortunately, there are still a lot of worries. Next slide. So I came here to Indiana for residency just a decade ago, and but I was born in I was raised in Kentucky, and kind of considered myself an Indiana transplant. And I will tell you, this past year has made me very, very proud to now be a Hoosier. It didn't matter what was going on when we reached out to hospitals, providers, businesses, partners. Everybody said yes. IHA has been a tremendous partner. The other medical associations across the state have been a tremendous partner, and they were on the late night phone calls with us trying to figure things out. So thank you for welcoming me into Indiana, and I'm just so incredibly proud of the work that we have done here, because everyone said, you know, what do we need to do to take care of our fellow Hoosiers? And there was a lot of teamwork. I mean, talking to other states, that was not happening in other states. The Department of Health was fighting with the hospitals, we're fighting with doctors, and they're just, you know, there was not this cohesion that we have seen here. And then, of course, the communication. Dr. Box and I have always tried to make ourselves readily available to anybody when they needed it. And we have found that everyone has been readily available for us to talk to when they needed it as well. Next slide. So where are we at now? Next slide. We are fully into vaccines and variants. Who would have known, right, this time last year that we would have, so today it's 1.6 million Hoosiers fully vaccinated. I mean, I like to predict things, read tea leaves and try and guess things, and I would have said absolutely not. There's no way that we'd be in a place where we would be able to vaccinate this many people. So I do want to be very transparent about where Indiana is with vaccines. So as you can see here on this slide, the lighter the color, the worse we are. So this is how many total doses are administered per 100,000. And you can see Indiana is lagging behind, unfortunately. So we have a lot of work to do here. Next slide. It is not entirely our fault. So also to point out that we have had we're actually second to last for number of doses delivered to Indiana. So how many doses we have been allocated from the federal government. So, I think that we could have used those doses a month and a half ago, 2 months ago, in order to accelerate all these people who are ready and willing to get vaccinated. But we have definitely reached this point, and this week it started, and next week it's very obvious that anyone who wanted to get a vaccine has gotten it. So we see a ton of appointment availability across the state starting this week, and then especially next week. So getting a lot more vaccine into Indiana right now would not be incredibly helpful. It's really, this is the time where it takes the work to get to those populations who are hesitant for whatever reason. And honestly, I believe it starts with us. I'm disappointed, I'm sure you all are, in the uptake in some of our healthcare workers. And, I think the community has turned to healthcare and healthcare workers this entire time to lead them through this pandemic. And this is another area where we need to be leading through the pandemic, right? So it's hard to go to a community and say everyone needs to get vaccinated, but only 30 or 40% of the people in the hospital are vaccinated, right? And so it's really starting to dig through what are the reasons behind that, what are the worries, what are the concerns, and help people get to the other side. So this is my first ask of you all, is assistance with that. And really, I think starting and looking at your workers and talking to your workers is a good place to start. Next slide. So something we are very incredibly proud of is our approach to allocating vaccines. And we did start by vaccinating elderly people. So people who we knew were at increased risk for hospitalizations and deaths. So we are leading for doses administered per 100,000 for the 65 plus. Why this is so important, that we are doing okay on plateaued on our hospitalizations, and really like low plateaued in deaths as well. And we do think that the vaccines are what's contributing to that, despite the fact that we've seen this uptick in cases. Next slide. But again, have a long way to go with these younger populations. And I'll talk to you a little bit more about that here in a couple slides. Next slide. And by the way, all those graphs that I just showed you are on the CDC website. So at any time, if you want to know where is Indiana stacking up to other states, that is where I get that information. So I do want to share you some zip code level data. Next slide. And this has actually been updated since April 12th. I just didn't change that data. I apologize. So this is uptake across Indiana by zip code. So wherever you're at in Indiana, please look at this map and see who around you needs your help. We actually have reached out to the Rural Association because we definitely recognize that we need assistance in our rural area. So red, if you can't see that little writing on your computer, is less than 10%. So that is bad, right? And the darker green, you get the better. So we are targeting right now, actually calling counties with low vaccine uptake, calling the individuals in that county to, give them an opportunity to ask questions, and then even are offering to sign them up for a vaccine. So, whatever efforts we need to do, we would appreciate, and we are looking to our hospital partners to help lead here. We have heard from a subset of the community that they only want to get the vaccine from their primary care provider or a provider that they would go to, and that would include a hospital or a primary care provider associated with the hospital. They have no interest in going to a mass vaccination site. They want to hear it from the doctors that they trust that this is the right thing to do. And also are not interested in getting it from a pharmacy. So we totally recognize that the storage and handling requirements around the vaccine is difficult. And so we're trying to come up with creative solutions to be able to help people. So Pfizer just updated about a little over a month ago their storage and handling. So you can actually take out however much vaccine you think you would use in 2 weeks out of ultra cold, put it into a normal vaccine freezer, give out vaccines over those 2 weeks, and whatever you have left over, you can actually put it back in ultra cold. You can only do that one time, but I think that is, one of the ways that we can maybe move some vaccine out of the mass vaccination locations that we have out into our primary care providers. And the CDC is doing calls and interviews with people who are hesitant across the country. And they also have found this to be true, that people are wanting to get vaccinated close to home. We also definitely have what I am calling Pfizer deserts. So we have pockets of Indiana where you have to travel pretty far, over 20 miles, in order to get to Pfizer. Why that is important is Pfizer is the only one that is available for 16 and 17-year-olds. And we still think that they're probably going to extend it down to 12-year-olds here in the next 3 to 4 weeks. So we're taking a good look at that and seeing what can we do to connect Pfizer specifically in those areas. So it is Northeast Indiana, just West Central Indiana, and then kind of South Central Indiana is where we're really seeing those Pfizer deserts. Next slide. So variants, they are here, definitely. So this is actually a little bit behind. So here it has Indiana listed at 23.8, and that was last week's. What percentage of our cases are from the B117 variant? This week it updated to 27%. So just a 4% growth just in 1 week, which is concerning. So you can see Michigan, which is, everybody has their eyes on Michigan right now. And we talk to our Michigan colleagues, they say 100% their high spiking cases, their hospitalizations, have all been driven by the B117 variant. They have also seen an increase in younger people getting sick, maybe not as many underlying comorbidities, and more in that kind of 30 to 50 range, which is not what we were really seeing before. So all the more reason that we need to do whatever work that we possibly can to get people, including young people, vaccinated. So we're following these numbers very closely. Next slide. This just gives you an idea of how fast these variants spread. So this is over time, week over week, and you can see that the B117 variant is quickly overcoming and becoming the most common variant that we have here in the United States. And of course, the P1 variant from Brazil, and also what's going on in India, we're very concerned about as well, and are hearing from those countries, again, that increase in hospitalizations in younger people, and definitely increased transmissibility with these. Next slide. So this is where we're at compared to other states around us, specifically with the B117 variant. Next slide. As I mentioned, this variant does have increased transmissibility, so more likely to be infectious. They are even seeing a little bit of spread in some of the younger ages that we haven't seen before. So something to be cautious about, and why we are continuing. One of the many reasons we're continuing the recommendations in the schools for masking and social distancing, et cetera, throughout the rest of the school year. And of course, that there's concern that may be with increased severity of illness and even death. Next slide. So this is where we're at with the P1 variant, again, here in Indiana, but in smaller numbers, and something we're paying close attention to. Next slide. As I mentioned, again, with this one, increased transmissibility with the mutation, and also increased risk of severity of illness. And our colleagues in Brazil say for sure, definitely younger people are getting sicker with these variants. Thankfully, we do believe that on the reports that we're getting and we're reading and hearing about, that the vaccines that we are using here in the United States, so Pfizer, Moderna, and then was J&J, and probably will be J&J again soon, are covering these variants, which is really good news. Next slide. So cases by age group, we are seeing an uptick in cases in the younger people, 20, 29 especially, and then the other younger people under 50. And thankfully, we're seeing pretty much plateaued. It actually has gone up a little bit in the older populations this week, but plateaued in this older populations where we have seen the best vaccine uptake. So lots of signs and signals saying that the vaccines are working. Next slide. So again, an uptick in hospitalizations, but it has leveled out. We don't see that super sharp spike that we were seeing before, but something still to pay really close attention to. Next slide. This just gives you an idea of how bad things are in Michigan. I mean, that you can't ask or can't see really much more of a growth rate than that. So that red spike here at the end is Michigan's numbers. And then Illinois is the purple line just below them. And then Indiana is that black line. So again, as I mentioned, Michigan does feel like this is from the B117 variant. Next slide. Next slide. So what's next? What are we talking about? So as you know, Johnson & Johnson paused, or they put a pause with Johnson & Johnson. They found 6 cases of the cerebral venous sinus thrombosis associated with thrombocytopenia, and that is really the combination that they were most worried about. We did hear from the White House and the CDC earlier this week that they only found a handful more of cases. So not this like large amount of cases, which, you know, with all the publicity could have happened. And that, so they're glad they've only found a small additional subset of cases. And so all signs are pointing to that ACIP meets tomorrow in the afternoon, that they will unpause. So the EU have started to give Johnson & Johnson again with a warning. And so that is the expectation that will come out from the meeting tomorrow, that it is extremely rare, you know, 1 in a million chance of having this combination of issues, but something that providers need to be aware of. So we are asking that make sure that your providers know, you know, especially your emergency department providers know, you know, what they need to be looking for, and they should make asking about have you been vaccinated part of their routine. So I still work in the emergency department 1 day a week, and I have made that a common part of my interview, even for people without presenting with headache or any of these other signs and symptoms, because it does give me an opportunity to talk to them about the vaccine, you know, and ask them, have you got it? Why not? What are you worried about? What questions can I ask, or can I, you know, answer for you? Next slide. So just for awareness, the case presentation, 5 out of 6 of these people presented with headache, and I assume that they will be giving us updates on these other people that they have found as well. 1 presented with back pain, but then subsequently developed a headache, abdominal pain, nausea, vomiting. 4 developed neurologic symptoms. And the median days for vaccination to hospital admission was 15 days. So about 15 days after they got the vaccine is when they developed these symptoms. So something for, again, for providers to be aware of. Next slide. So as I mentioned, the worry here is the clot with the thrombocytopenia, and that these patients' clot was found, or they had PEs or whatever the case may be, and heparin was given, right? That's what you give for clots. Now the problem is that they did have the anti-PF4 and then subsequently had hemorrhage. So that is really why we need our providers know to look for that specific combination, because they do not want to give heparin in these cases. Next slide. So instead, they are supposed to give non-heparin anticoagulants, and then IVIG, and then consult a hematologist. So then again, just remain a high index of suspicion for headache, backache, new neuro symptoms, and the setting of receiving the Johnson & Johnson vaccine in the last several weeks. Next slide. Just more information. We have to remember that all providers are required to report information to the VAERS system, so the VAERS reporting system for adverse events. That's the only way we're able to find things like this. So this is a good sign that our system here in the United States is working. And then, of course, not to treat these patients with heparin and to do a hematology consult. This is a send out for most hospitals, this test. So they need to not give heparin until they get this test back. Next slide. Next slide. So we are working, like I said before, to increase vaccine locations. I think we're seeing the end of our use for mass vax. Even if they were to extend down to 12 years old, we have enough vaccine and enough vaccine appointments in the state of Indiana to accept all of those patients and get them done in just a couple of days, if all 12 to 15-year-olds were to get vaccinated. So we are looking to start to back down on our mass vax locations, especially the hospitals here in the next couple of months. We are still going to make sure that local health departments provide vaccine clinics. Our pharmacies are continuing to provide vaccine, but we really need to get it back into the more traditional ways of giving vaccines, so primary care, urgent cares, and pharmacy. Next slide. So where are we going even further after that? So we do know that like I said, they've already applied for extension of the EUA for Pfizer for the 12 to 15-year-olds, which we would expect here in the next several weeks. And they started studying it in 6 months to 11 years old. Next slide. Moderna has also started its trial back in December for 12 to 17-year-olds, and then are beginning with 6 months to 11-year-olds. Johnson & Johnson is planning the same. Next slide. As you guys are probably aware, people really shied away from any healthcare for quite a while last spring and early summer. So we also saw a significant decrease in our emergency department admissions, or people visiting the emergency department, and we've also seen this in primary care. We do appreciate all the work around telehealth, but there are some things that you need to see people in person for, and one of those is all for other vaccines. So when I'm talking to providers, I make them aware that we have seen the significant decrease in vaccinations in younger people, to make them think more about the vaccine preventable diseases, right? That they maybe normally wouldn't see on a regular basis, but because we've had a significant decrease in vaccines, that they may come up. So a measles outbreak, mumps outbreak, pertussis, things along those lines. And please, as critical access hospitals, do anything and everything you can to assist us so that we can get all of these kids, young adults, caught back up. Next slide. My other plea to you is to think carefully about your visitation procedures. So another thing that, Dr. Box and I have done throughout this pandemic is taken the phone calls of families and of patients across the state who were affected by the visitation policies. Myself, my family, and Dr. Box and her family were personally affected by this as well. I think we know how to protect ourselves now. We know how to protect the visitors. We know how to protect our patients. And so if we were to see another, spike in hospitalizations, which I hope we don't get there, because we're all going to work so hard to get more people vaccinated, think very carefully about your visitation procedures. Completely appropriate to reduce, and this is not a free-for-all, everyone running around the entire hospital, but we do strongly, strongly believe, and all the evidence supports, that people in the hospital do better, the family does better when they are allowed access to see their loved ones. Next slide. So I heard a little bit that you guys are going to be doing some wellness later. This is, we're actually for the Department of Health even looking to bring in somebody for the Department of Health from the National Guard to talk about re-entry into society. So essentially for the last year and a half, we have all been on deployment. I know all of you have been doing meetings from 6 a.m. in the morning to 10 p.m. at night. You were doing your own phone calls in the middle of the night. You were taking the phone calls from the families and from the patients that were worried about visitation or worried about COVID. So we fully recognize that you guys have been in the trenches and with us, but this is not sustainable, and also fully recognize that as things are getting better, that change in your cadence of all the meetings and all the stress and all the unknowns, it's hard to transition back into normal life. So even with me, with my family, I know, when I started to have a little bit more time, I felt anxious, like, what am I doing? What am I missing? Checking my email 1,000 times and seeing that there was none there, thank God, after months and months of 600, 700 emails a day, and really just kind of had to slow myself down. And my team, I'm seeing it in my team as well. And you may be seeing those kind of signs and symptoms in your team. So next slide. Just make sure you're talking about it. I think the first key is recognition, is recognizing when you are feeling that way, that there's a reason for this, that I have been on high alert for over a year now, and that there is a normal, right? I don't think we're going to ever be totally where we were before, because we've all lived through this together, right? So we're always going to think about things a little bit differently, do things a little bit differently, but we can at least slow our cadence, start getting back to some of the other things that we were doing, but we need to be paying attention for all these signs and symptoms. And I hope that you are all reaching out to your clinicians, your providers, and your staff to talk about these things as well. Next slide. Next slide. So this is my email. Like I said, I am always available. So if you want to get a hold of me, please email me, lweaver@isch.in.gov. I try to respond within 24 hours. I think if you've ever emailed me before, you can agree that happens. I probably will have to slow that down at some point myself and make sure that I have some wellness for myself. But right now, we just want to be here for you and at least connect. If I don't know the answer, I can connect you to somebody who does. So I am open for questions.
Dr. Weaver, there is a question in the chat box that says, how long does the vaccination last for COVID? Have been asked by patients and community, will we have to get this yearly?
So those are all the unknowns. So Pfizer and Moderna have both come out and said that the antibodies last for at least 6 months. I think, unfortunately, the way some of the headlines are written, it came across as only 6 months, but it's not only 6 months, right? We're still we're not even a year out from those first people getting their vaccines, right? Those big trials happened last summer. And so they've continued to follow them and check for antibodies. And they know that they're continuing to have antibodies at least 6 months out. So they're going to continue that, right? So whenever it was that they said yes for 6 months, I would expect, a couple months from then, they might come out and say, okay, it's 8 months, right? It's 9 months. We just don't know. Pfizer and Moderna have both said that they are preparing for boosters in the fall. And again, those boosters will to cover variants, and then maybe an annual vaccine every year, just like the flu in the future, but we just really don't know. So when we're talking to the CDC, they're also saying it's just too early to say. So we'll see how it shakes out in the next couple of months. I mean, if I've learned anything this year, we in medicine have always scrutinized every single, research study, new information that comes out. I mean, to the point where it takes years to change doctors' practice, in the hospitals and primary care, et cetera, right? Because they just really want to make sure that all the evidence is in place. So what we have learned this year is that we can be agile, right? We can work with it, the best information that we have in front of us, and then make decisions based on that. So that's not going to go away anytime soon, as we continue to see these variants and trying to figure out, with the vaccines, what is needed and not needed in the future.
So I don't see any other questions in the chat box, and we do have a couple people thanking you for your tireless work. You're a phenomenal leader, and we'll have to recover yourself from all your hard work and dedication towards healthy, vaccinated Indiana. Thank you for all your efforts. But no other questions.
This is Becky. I had a couple of questions chatted to me directly. The first one is, have there been any known pre-existing conditions for the 6 women who had had the clotting disorders?
So no, they were not, it wasn't like all 6 of them had obesity or diabetes or anything. I mean, a couple of them did have pre-existing conditions. Again, they're worrisome ages. What they're stating is between 18 and 50. They are also all white women, but the numbers are so low. You couldn't say that these things are risk factors, right? I mean, you wouldn't have to have much bigger numbers to make any statements around that. So my guess is that and this is Lindsay's guess, that they will come out with a warning tomorrow and say that there is a very rare risk of, this clotting condition with the thrombocytopenia, but without any other kind of specific risk factors.
Thank you. Another question in chat is, what are your suggestions on how to approach the ones that are waiting, the kind of the wait and see approach?
Yeah, I think it's really more getting into the why are you waiting, right? It's the why you're waiting because it's new. Then I think the fact that millions of people across the US millions of people across the US have been vaccinated, and 1.6 million here in Indiana have been vaccinated with a very good safety profile, right? Like, then it's what are you waiting for? If it's you're worried about future side effects, which one? So, one that's really going around right now is the fertility issues with young women. And we hear that over and over again from young women, why they're not getting vaccinated. And there's no basis in science behind that. So we have that available on our website, rshot.ion.gov, to talk through that. And that's also available on the CDC website to talk through the myths about that as well. So I think it is really kind of getting at the why are you waiting? Other people, say, I had COVID and it wasn't too bad, and that's why I'm not going to get vaccinated, or I had COVID and I don't think I need it because now I have antibodies, and there's just lots of unknowns with that, right? You don't know that just because you had it one time that you will be okay the next time, especially with these variants. For the young people don't get that sick. Well, maybe not before, not very many did, but some still did, right? We've had 85 MIS-C cases in Indiana. So it's very small, but it's not small for those families of the kids that had that, right? And we've had 20-year-olds and 30-year-olds die from COVID here in Indiana too. So your risk is not nothing when you have a vaccine there that can help you and also help protect you from spreading people who could get very sick. There is definitely people who the vaccine doesn't work for. We've had several people who've received transplants and are on immunocompromising medications, or people who are on chemotherapy where they did not develop antibodies after the vaccine. So it is definitely the case where you're not just protecting yourself, but you're helping to protect others as well.
Okay, so one other question. We are now doing monoclonal antibody infusions in our infusion clinic. We're seeing new positives with populations that have recovered and been vaccinated. Is there a waiting time before they're eligible for the infusion?
Oh, that's a great question. So I know if you've received the infusion, you can't get the vaccine for 90 days, but I do not know the reverse of that. So I will look into that for you. We do have breakthrough cases here in Indiana. When you do the numbers, right, even the trials came out, the best vaccine said it was 95% effective. We're not even, we don't even have 5% breakthrough cases. It's closer to that, 1%, even less range. But it definitely is possible. But I'll find out that information for you. I've not heard of any restrictions about when you can give it after vaccine.
Okay, and then the last question is, when is it safe for pregnant women to get the vaccine?
I would have pregnant women talk to their providers about it, but what I'm hearing from OBs is that they're recommending it in the second trimester. So after baby's formed, and mom's in kind of that sweet spot before, so they can make sure they have all those antibodies to give to babies. So as you know, or probably have seen, that they are detecting antibodies in babies that are born to vaccinated women. So that's very exciting. And they're also detecting antibodies in the breast milk. So another great reason to breastfeed.
There is one more question. Why wasn't the monoclonal antibody infusions offered to more people?
So in the monoclonal, as soon as we had it available here in Indiana, anybody could have received it. I mean, it just would take a provider to, write the prescription or give the referral to get the antibodies. What we didn't have is a lot of locations who were able to figure it out quickly on how to give it. So now that we are receiving more and we have more locations, it should be more readily available.
Okay, so if there's no more questions, we just want to thank Dr. Weaver for your presentation. There is one more comment that says they had a patient this week that was saying they wouldn't get the vaccination because they didn't want to have anything to do with Bill Gates. I can only shake my head. I don't have any argument that would work there. I don't know if you want to shed any light on that, but probably not.
No, I mean, I think we recognize that there is this pocket of the population who just will not get it. And we can't hold ourselves accountable for that, right? I mean, everybody has some personal responsibility. I will tell you, in talking to the CDC, they have seen really good movement in our minority population, specifically our African-American and Hispanic populations, in their willingness to get vaccine. So before, when it was in like the 30%, so that they are willing to get the vaccine, that has moved up, like almost doubled, who states that they are willing to get the vaccine. And are considering it or have received it, et cetera. Where they have not seen movement in people saying that they're willing to get vaccine is in white, men, less educated, and younger populations. So I think kind of to go back to that map that we show a lot of rural communities that are still in that orange range, and even some red areas as well of decreased vaccine uptake. And so I think that we just need to make sure that we are targeting every population that we possibly can. Where we have found a lot of success in getting people vaccinated, where our mass vax clinics are starting to really slow down, is in directed outreach. So our hospitals that have worked with a local faith-based organization or a local community-based organization, and when that leader, so that that preacher or the leader of the community organization gets vaccinated, then the rest of the congregation will follow. And so we really appreciate the hospitals that have been doing that direct outreach in order, to assist us. We also know some local health departments are doing the same. We've also seen great strides with our business and industry. So if you're not aware, we are giving vaccine directly to businesses and industry. Maybe some of you have helped out a local business or industry in giving the vaccines, and we have seen improved uptake at those locations as well. And of course, our college and universities have done a really good job of vaccinating that subset. We are going to be doing a lot of promotion around vaccinating our 16-plus-year-olds, including we've in Lake County have invited those schools to bring their kids to the Gary site. We are inviting Marion County schools to bring their kids to the IMS site, and we're going to continue to expand that project and are encouraging our local health departments to do the same thing, to do outreach to their high schools and kind of make a day of it. I think when other people see that others around them who they relate with, who they consider their peers or their colleagues, get vaccinated, they're more willing to do that.
Great, thank you so much. There are no more questions. We appreciate your time today.
Actually, I did have a question emailed to me. This is Becky. Who all can report in the VAERS system, and should we be promoting that to any other groups besides provider groups?
Anybody. So anybody can report into that system, even the patient themselves or a family member. It just kind of takes you through different questions depending on what you think. I also always encourage people to sign up for vSafe when they get vaccinated. And that actually, is an application that you can use on your phone to report symptoms or if you have any adverse events. But anybody can report into VAERS.
Okay. And then another question is, now that vaccines have been given for a while, are there any pre-existing conditions that you should recommend one vaccine over the other?
So no, they are all, the best vaccine is the vaccine in front of you. Even with this Johnson & Johnson, they, at least from what I've seen, the data I've read, there's not a specific, anything that says that you're at higher risk for the super rare condition. So no, at this point, get vaccinated. We do know there's a large part of the population too, where like, I just want one shot, whether it is they don't like needles or just the convenience of it or whatever it is, and are holding out to get the Johnson & Johnson. So I'm really hopeful that they're going to unpause tomorrow so we can proceed with using that vaccine as well.
Great, thank you.
Thank you.
At this time, I did want to point out in chat that Annette Handy shared that IHA has some resources available through Signasure. And so Annette, or if someone from IHA would like to elaborate on those resources that are available to help with those difficult conversations. And maybe Annette got disconnected, but please click into that web link. I know there are some great resources out there.